Today, I'm supposed to talk about how to choose wisely in medical oncology. So, as Professor Larry spoke about the initiation of this campaign, which is about 10 years ago, and it was brought about the escalation of the cost of taking care of cancer patients in the United States. And later on, ABIM is a foundation led by physicians, which launched a campaign called Choosing Wisely campaign, where more than 80 professional societies were invited. And they came about with 550 examples of unnecessary low value services in medical care and about 180 recommendations. Yeah, so I will go straight to about 11 important recommendations which are adopted by the ASCO, which is Association of Clinical Oncologists in America. The first one is about screening, where it is saying that don't routinely perform PSA testing for prostate cancer screening in men with no symptoms of the disease. Actually, what I have highlighted in these slides are important trials which has shown no benefit in doing PSA testing for prostate cancer screening in men with no symptoms. The only fault of these studies did not include high-risk groups, which are African Americans and those with relatives who have died from prostate cancer. So in these randomized trials, tumor found through PSA testing grow so slowly that they are unlikely to be life-threatening. Detecting such tumors is called overdiagnosis, and treating them is overtreatment. A false positive test results may create anxiety and lead to additional medical procedures such as prostate biopsy that can be harmful. In the side of diagnosis and staging, ASCO have adopted don't perform PET, CT, and radionuclide bone scans or newer imaging scans in the staging of early prostate cancer at low risk for metastasis. Because at this stage, if you find no metastasis, it is well and good. But in case you find some lesions somewhere, you might not be sure whether these are really metastasis or not. And this can lead to overtreatment of the patients, which will increase the cost, and it will be more harmful because of the treatment side effects. Still in diagnosis and staging, don't perform PET CT and radionuclide bone scans in the staging of early breast cancer at low risk for metastasis. And when we talk about early breast cancer, we are talking about ductal carcinoma in situ or node-negative invasive breast cancer, 2 centimeter or less, hormone receptor positive, HER2 negative ductal carcinoma, okay, that is a repetition, or clinical stage 1 and 2 breast cancer, because these tests have not shown any impact in the detection of metastasis for this group of patients, even in improving survival. Coming to treatment. Don't use cancer-directed therapy for solid tumor patients with the following characteristics: low performance status, WHO performance 3 or 4, no benefit from prior evidence-based interventions, and no strong evidence supporting the clinical value of further anti-cancer treatment. In this group, unless you have patients with the highly sensitive, with the solid tumors which are highly sensitive to chemotherapy, like seminoma, then you can think about doing something. Otherwise, the rest, this treatment will be ineffective and more toxic to the patient. Rather, patient is best to send them for best palliative care. Don't use combination cytotoxic chemotherapy or multiple drugs, polychemo, instead of chemotherapy with one drug when treating an individual for metastatic breast cancer, unless the patient needs a rapid response to relieve tumor-related symptoms. So here we are talking about patients with metastatic disease and with good performance status. We are supposed to not to use the polychemotherapy. Rather, we can use mono chemotherapy, which will have good benefit. The polychemotherapy will not have more benefit compared to the monotherapy. Same in the treatment. Don't use white cell stimulating factors unless the expected risk of febrile neutropenia associated with chemotherapy agent or regimen is equal to or greater than 20%. Yeah, so usually sometimes we do prophylactic GCSF, like filgrastim. This is not allowed unless you have a protocol which evidences have shown that it has a risk of febrile neutropenia of 20% and above. Yeah, so another recommendation is don't give patients starting a chemotherapy regimen that has a low or moderate risk of causing nausea and vomiting antiemetic drugs intended for use with a regimen that has a high risk of causing nausea and vomiting. Usually, highly emetic chemotherapy, we do provide 4 drugs, which is a combination of neurokinin receptor antagonist, serotonin antagonist, dexamethasone, and the olanzapine, which is the antidepressant. So this regimen should not be used for moderate risk or low risk emetic chemotherapeutic agents. Otherwise, we should only be used for those which are highly, they have high risk of causing emesis. Another recommendation is don't use a targeted therapy intended against a specific genetic aberration unless a patient's tumor cells have specific biomarker that predict an effectiveness to that particular targeted therapy. So here, it emphasizes the importance of doing immunohistochemistry to the tumor cells to identify the genetic alteration that predicts that that particular drug will have effectiveness. Otherwise, we might increase the cost to these patients because these novel agents are expensive. So without having the genetic test, we should not embark on administering them. When we come to surveillance, we have some few recommendations, like don't perform surveillance testing, like biomarkers or imaging, like PET, CT, and the radionuclide bone scans for asymptomatic patients who has been treated for breast cancer with curative intent. We all agree that in our daily practice, we come across patients who has been treated with curative intent. And then patients have no any symptoms, but sometimes we feel like we need to do some fancy testing so that we can detect recurrences earlier. But most of the time, this is not the condition. So we are supposed to do these tests to patients when they present with some symptoms, especially if they were treated with a curative intent, to avoid the unnecessary cost to the patients. Also, avoid using PET or PET-CT scanning as part of routine follow-up care to monitor patients for cancer recurrence in asymptomatic who have finished the initial treatment to eliminate the cancer unless there is a high-level evidence that imaging will change the outcome. Actually, this one resembles the previous recommendation. Do not obtain routine blood work, e.g. Complete blood counts, liver function test, or renal function test, other than a CA level during surveillance for colorectal cancer. I think this recommendation was also told by Professor Larry when he was talking about the surgical part of our theme. So after going through the Choosing Wisely documents, the scope of recommendation span the cancer care continuum. It means there is recommendation all the way from screening, diagnosis, treatment, surveillance, and even survivorship. Most recommendations focuses on avoiding unnecessary laboratory tests and imaging, rather than decreasing treatment that are harmful, costly, and invasive, e.g. Surgical procedures and radiation therapy. The recommendations frequently targeted some lower risk cancers susceptible to overtreatment. Like what we have seen, there are recommendations for breast and prostate. So, but there are other malignancies like thyroid cancer or non-melanoma skin cancers, which also need to be to be addressed, because the issue of overtreatment, it is not only for these two types of cancers. We need to increase the focus. So these gaps represent not only areas for actionable improvement, but also an opportunity to enhance the value of these recommendations for patients in cancer. Focus has to be expanded, as I've said, to a broader set of cancer types, which has lower risk and are susceptible to overtreatment, with a renewed effort to target the cancer therapies and the services that, when overused, are associated with the greater cost and patient harm. Thank you very much.